Hello, and welcome to the Nurse Linda webinar. I always start off by saying how happy I am to be here today, but it's really true. This is like my happiest hour of the whole month. So it's always nice to be here with you today. There's a lot that's going on in medical research in general. There's a lot that's going on just in the world of neurological injury. Now, I know that somebody wrote in and they'd like to hear more information inclusive of stroke patients. And I try to talk about neurological injury because that includes both. But I'm going to be more mindful about mentioning stroke so that is more clear for everyone because a lot of neurological injury through trauma or through disease. We call it injury. So sometimes people think, oh, that's only brain injury or that's only spinal cord injury. But neurological injury can be from trauma or it can be from disease. So it's an inclusive term. I was just thinking the other day about all the medical terms that we use that science has now surpassed these words. So it gets confusing for people when we talk about neurological injury because people think, oh, that's only trauma. That's only for people who've been in accidents. But no, it encompasses everything. So as healthcare expands, we have to think of better terminology. It's really hard to change terminology when you're talking about healthcare. So, like right now, when we talk about spasticity, so those muscles that are tightening and contracting, and when we talk about spasticity, the new word is tone. So I try to use the word tone slash spasticity so people will know because most people have not heard the word tone and most medical professionals have not adapted that word. But if you're in neurology, you call it tone. And if you're out in the rest of the world, you call it spasticity. So it gets real confusing for people what we're talking about. So I try to clarify. So I'm going to be more cognizant about including stroke. Now, I wanted to take a moment just to pay tribute to a very good friend of mine that we lost this year, but he was such a um, man amongst men as far as advocate for spinal cord injury. He had had a spinal cord injury when he was 21 and lived until the age of 88. He was what I would call a mid-level quadriplegic. He was not vent dependent, but he was right below at the level, about C4 or 5, right below vent dependency. So he had a lot of challenges in life. But when he was 21, which when you live to 88, that's quite a number of years ago, there was not a lot of rehab like there is now. And there's certainly, now we've had this boon of information and new devices that are coming out and all these different items on the table that are being developed right now. We're in this renaissance period for treatment of spinal cord injury and stroke and brain injury. And so there's so many things, but back when he was 21, which would have been 60 years ago, there was just not a huge amount of resources. You had your rehab and you stayed in rehab a long time. Sometimes people stayed a couple of years in the rehab hospital. And that sounds so bizarre today when people some often get 2 weeks. I meet people who get 2 weeks in the rehab facility. If it's spinal cord injury, brain injury, stroke, that's what their policy calls for, and that's what they get. And it's just uh, harrowing for the family. So anyway, but my friend Robert Husky, such a wonderful man, very active in the community. Just one of these individuals that studied spinal cord injury, and we would see each other at different events. We live in the same community, and we would see each other at different events. And he'd roll up and he'd say, "Linda, what's new going on out there? What's new in spinal cord injury?" And I would say, "Bob, there's new things going on, but you know more about it than I do," because he had made a lifetime of this. He was very active with getting children's sports programs adapted for children with all sorts of disabilities and just perpetuating, working with insurance companies, working with the VA, working with information, getting it out, peer support to other people, just one fabulous individual. So anyway, I thought he would be kind of standard for people. You can be injured at a very young age at 21, and he still lived quite a full life. He went to, I think he went, he liked to travel, and he went to something like 135 countries in his lifetime, and he'd been all over the United States, and just it just did not slow the man down at all. So, and he lived to a nice ripe old age. What happened was the COVID. But this was just recently. So the COVID's still out there, can still affect people. So just be cautious and beware. So anyway, um, I'm sure Bob Husky and Christopher Reeve and my husband are up there all having a great time together, doing whatever it is they're whatever it is they're enjoying doing. So we have some questions, and the first question I want to talk about is skincare. And people who have paralysis from any source, be it spinal cord injury, stroke, brain injury, multiple sclerosis, Guillain-Barré, um, ALS, anybody who has decreased sensation in their body for any reason is subject to pressure injury. Even older people that just sit all day are subject to pressure injury, or people who do a lot of sitting. Now, um, most people, when they sit, they're moving around. You'll see me, I'm moving. People are constantly moving. But as your body slows down, sometimes, or you have paralysis, slows down with aging, you have paralysis from any source, you don't get those signals to move your body. So we move our bodies thousands of times a minute, just a little bit, just a little hair, just a little something here, there, and hither and yon. But when you have that decreased sensation, it's hard to move your body. You don't get that feedback. And so pressure injury becomes quite an issue. And this person that wrote in is saying they have a chronic non-healing pressure injury wound on their right ischial and trochanter bones, so on their hip and on the bones that they sit on when they're sitting. And it has osteomyelitis, so there's infection in the bone. Whenever anything ends in itis, that's an infection. And so they've tried all different kinds of things. They've had a wound vac. They've done skin grafts of various kinds. And they've done bed rest, being off the area for 3 years. And so they want to know anything new, anything else, what other kinds of things. So we'll just start from the beginning, because this covers everybody with paralysis can get these wounds. So the first thing you want to do, and this is not for this gentleman because he's doing everything he can do, but the first thing you want to do is do those pressure releases, because you don't want a pressure injury to develop, because when that skin closes and it grows back, it's not elastic, it's a scar. And scar tissue does not have the elasticity that your usual skin has. So once you have a pressure injury, you're at a higher risk for more pressure injuries. Now, another thing I want to point out before we really get into treatments is that individuals who have pressure injury, oftentimes, and in the past, this has been true, and I hope that it's not true in our healthcare professions these days, but it probably is, because this is, if you've been around for a long time, it was this way early on. But when somebody would come in with a pressure injury, oh, you're not doing your releases. Oh, you're not cleaning your skin well. Oh, this, oh, that. You're not using your pressure dispersing equipment. And some people don't really do much with that, and they don't have pressure injuries. Some people do everything by the book, by the book, by the book, and they have pressure injury all the time. And so what we know now is it's that pesky little autonomic nervous system, the part of the nervous system that responds automatically to things like breathing. I don't have to sit here and take a breath in, Linda, let a breath out, Linda. I don't have to tell my heart to beat. I don't have to tell my immune system to be on guard for invaders, to, destroy the invaders in my body. It's just all happens automatically. My bowel works automatically. My kidneys work automatically. My bladder will fill to hold urine, but I have control over when it's appropriate for me to empty it. So that, there's some things you have control over. You can still hold your breath, but your body's going to breathe because your autonomic nervous system is going to cause that to happen. So what we have found is that, and this became especially now, researchers and doctors have always considered this, but it's become especially more aware in the public about the autonomic nervous system because during the COVID, we talked a lot about people being more susceptible. Um, well, anybody could get COVID, anybody could get flu, anybody could get RSV, anybody can get a cold. Those viruses are just in the air. But once you get that, because of your autonomic nervous system, it was felt that people would be more susceptible to letting the COVID go running wild in their bodies because the autonomic nervous system might not tell the brain that there's an infection in the body. Or it might not tell the brain quickly enough, and then that infection is allowed to really take hold and multiply before resistance can be built, or there's just no message that's even sent. So you have these white blood cells that are circulating around in your body. You have protein, you have all these different things that are circulating around in your bloodstream, and they'll detect an invader, and then, even though those cells are not connected to a nerve, they signal the nerves that there's an invader in the body. And then that message is sent, just like in a snap up to the brain. And the brain will then send down a response to, let's get rid of it right away. But if the autonomic nervous system's affected, that may not be able to help to transpire in that way. So we know that with infection, or we know that some people, they're doing everything they can to prevent a pressure injury, they still get them. Other people do nothing to do that to protect themselves, and they don't get one. Why is that? Well, it's this response of the autonomic nervous system. So it's kind of an interesting thing because you think, gosh, I'm always so excited about how fascinating the body is in how it works. And when you think this is almost like magic, but it's not, it's physiological. So when you get those infections, sometimes they're harder to get rid of because the autonomic nervous system cannot mount that defense. Now, another thing that happens with infection is that some people, they get their antibiotic, and they take maybe half a dose and they feel better. And so they stop taking it because I'll save the rest and then I won't have to call the doctor next time. I'll just take it when I get an infection again. Antibiotics are created so that they start killing the bacteria or antivirals or antifungals or whatever this infection is, the source of this infection. Those drugs are created to start winnowing down that infection. So you might feel better, but the infection is not gone unless you take the whole course of treatment. So antibiotics, maybe you're on a 10-day course and you think I'm feeling better after 5 days, so I'll save the other 5 days of treatment for a later time. You've not killed your infection. So you will get another infection. So you have to take that whole course of drugs. Now you want to try to avoid infections, so you can try to, not take so many antibiotics. And this is kind of a conundrum, but sometimes people will wait, the infection will get bad, and they have to take a real high level, they call them generations of antibiotics. So you have like the penicillins, ampicillins, those are your first generations. When you get up to the vancomycins and those kind of powerhouse antibiotics, those are like third or fourth generation antibiotics. So always take the full course and always get your antibiotics as soon as possible, because you can take lower level antibiotics so that if you have a super infection, then those higher level generation antibiotics will work for you. Now, there are some people that just shoot right up for the, well, I want that big one because it knocks it out right away, and I want the big antibiotic. And now we have infections that are resistant to those antibiotics. And so there's not really a treatment for some strains of bacteria. Now, that doesn't mean that if you did this, if you took your antibiotics incorrectly, that doesn't mean you're going to get a super infection, or it doesn't mean it's not going to be able to be treated. This is just one course that could possibly happen. So back to our friend who has this infection in their wound. Wounds with infections are more difficult to treat than wounds without infections. And when that infection gets into the bone, it can travel to the bone marrow, and then it can travel throughout your body. So be sure you have the sepsis card for our person who's written in, the sepsis wallet card, so that you know the signs and symptoms of sepsis. Now, sepsis is a kind of a rare thing. We're hearing a lot more about it because it's a public health notification. We want people to think about it, because if you can get a wound that become sepsis in the wound, it can turn septic, which means that it's starting to go to other organs in your body. And if you have a septic infection throughout your body, that infection has traveled all throughout your body. You can have an infection and not even know you had an infection, and you can still become septic. So it's not that often seen when you go to the emergency room. It's one of those things we'll get out. It's kind of one of those diseases that's out there. And so when people start treating, somebody comes in with a fever, they're going to start with the first things first and work up the hierarchy, which sepsis is going to be up at the top. But they're going to try to see if it's this, is it a little something that we can put an antibiotic ointment on it? Can you take a pill? Well, by the time you work through all those stages of things, you can become septic. And when you really get bad with a septic infection, you have about 1 hour to treat that. So you really have to pay attention to that. So what the Sepsis Alliance and the people who are specialists in sepsis want us to say, when we have somebody who suspects they've had an infection, now they have something more that's going on, they want us to tell you to go to the ER and say, could it be sepsis? Look at my wallet card. Could it be this? When the nurse comes in, tell them. When the doctor comes in and tells them. If there's a resident or intern, every time somebody comes in that room, say, could it be sepsis? So that kind of puts it in their mind to think, you have risk factors. We should test for sepsis right away instead of waiting until it grows and grows and gets worse. So with that infection in the bone, I want you to be really prepared with that wallet card. So now you've done a lot of treatments for this, and these are my suggestions to you that you might want to investigate. There are all kinds of wound care treatments. You can get them on the internet. There are medical preparations, medications, ointments. There are things to take debris out of the wound. There's all kinds of treatments. So you need to look at what treatment's going to work best for you. Now, in this case, with the wound, with the infection in the bone, they might not want that wound to close over until that infection is cleared up. Because if the skin on the top is going to want to close, that's the way the body protects itself. It's going to want to close and form a scar, and then it'll work from the inside to heal that wound. But in pressure injury, we always try to keep the skin open with packing. So if you've had a severe pressure injury that's in deep, you pack gauze with maybe some kind of ointment or wet to dry gauze in that wound. You pack that in there to keep that skin open so that the wound heals from the bottom up. With this infection in the wound, if the skin heals over the top, you have created a perfect incubator for that infection to get worse. So the fact that it hasn't closed up yet is probably by intention, but because of that infection in the bone. So now how do you get rid of that? Well, there are all kinds of antibiotics. I'm going to assume you've been on those because, you've been dealing with this for a long time. You've done a lot of advanced treatment, so you're obviously getting good care with trying all these different kinds of things. So you'll have to find out what that infection is and how it can be treated. Now, very rarely, and I'm not recommending this in any way, shape, or form for you, but it might be a consideration on the table. Sometimes they'll take out that piece of bone with the infection in it. There are risks with that. If you take out that bone with the infection in it, that can release the infection into the rest of your body automatically. It can release it through the bone marrow, which travels all through your body. So it's a very risky kind of thing to do. But if it's just in one part of that bone, they might be able to take that bone out and relieve that infection. Sometimes that occurs to people, but now this is like way out there. You would want to try to treat it with antibiotics so that it doesn't have to happen. Once that piece of bone is taken out, if it's like on a joint or if it's a supporting bone or if it's a big chunk of bone, they will probably need to put a prosthetic in because, your skeletal system holds you all together no matter what part of that skeletal system is disrupted. That's going to disrupt everything in your skeletal system. So they usually will put a prosthetic in there. Prosthetics love to be a place where infection can hide and hibernate. Interesting sidebar. So I have met several people recently that have had knee replacements, not any kind of neurological injury, but they've had knee replacements in the past. They have gotten COVID and maybe they've had their knee replacement like 2 to 5 years ago. And the COVID has settled in the knee replacement. And so then they have to go in and they have to clean all that out. And again, there's that risk of sepsis. They have to be on antibiotics, through a tube, a catheter that goes right into the chest. It's really nasty. So you really want to try to get that cleaned up without having the bone removed. But that is something that they do. The other thing about that is, so once that infection gets cleaned up, then you can move forward with getting that wound cleaned. Now, and getting that wound closed. Now, there is another thing that's coming up. What's going on out there in the world? People always want to know. My friend Bob, what's new, Linda? Well, since they've developed the COVID vaccine, that used new technology for delivering vaccines, but it can be for vaccines, it can be for a variety of things. It uses a new technique. Now, people were all upset because this was a new technique and they just invented this technique. And how will we know it's safe? Well, it wasn't just invented. Scientists have been working on this technique for 30 or 40 years, and maybe even longer. 30 or 40 years since I've been following it because it was so cool. You know how I am. I got to know all about these things. And so what they could use this technique of injections to for measles, mumps, rubella, they could use it for any kind of vaccination that people need. But we already had vaccinations for those. So, it didn't make sense if you had something effective to then move to this other thing. So really, when the COVID came along, they had already perfected the technique. They just needed to direct it towards a virus. This was a new virus for which there was no treatment. And so they had already experimented with how this technique would be used and how it would work. And they already knew that it would work. They just hadn't done it on such a mass scale before. So that's kind of an interesting little side fact. However, what they're doing with this vaccine now is when people have an infection that cannot be cured, this is all experimental. It's being done, but it's all very experimental. So could you get this? Well, yes, you could. It's possible to get this. Is it probable that you could do this at this point in time. It's not very probable because this is still an evolving science. But what they're doing is they're taking people who have these infections that cannot be cured. They're getting the DNA from the bacteria or the virus or whatever it is that's causing this infection. They're able to do the genome of that infection and then to create a vaccination that will do nothing but destroy that infection. And the way it does is like with the COVID vaccine, it affects the cell of the infection. So it affects each individual cell, but it affects the film that holds that one individual cell together. And so it can't multiply and therefore it dies because that's all bacteria and viruses. They don't have nervous systems. They can't think, they can't reason things out. The only purpose that they have is to multiply, to keep the species, the infection going. That's their only purpose. And they take over parts of the body and viruses will infiltrate those cells. Bacteria will live on the surface of tissue, but viruses infiltrate those cells. And so they'll create a vaccine that will be unique to that virus and it will just kill that virus. So now how would you even find out if you could go about doing this? You would have to talk to somebody who works in immunology at an academic medical center who would be willing to take this on. You would probably have to go to the operating room to have a sample taken of this infection because, it would be opening up that area even with that little pinprick of the needle to get that piece of that infection. And so it'd have to be done under sterile situation. And then they would take that to a lab that would get the genetic code of this particular infection, create the vaccine, and then then you would get a shot in your arm. And that would be your treatment. My gosh, after all this, and you could get a shot. Now, as I say, it's probably not probable that this will happen, but this is in the future. Now, if you've been listening to the TV, you have heard about a pediatric hospital in Philadelphia. It's called Children's Hospital of Philadelphia. Everybody calls it CHOP for short because its initials is CHOP. So CHOP, very well-known pediatric facility, as there is a very excellent pediatric facility, academic oriented in every state. So I think in every state, and they're specialty hospitals. So they are amongst the top for pediatrics, but there are other ones as well too. So, don't think, well, I don't live in Pennsylvania, so I don't have access to that. You have access to academic pediatrics in your own state. So that's good. But at CHOP, they did this experiment on these 8 children who got a virus, and it was an unknown virus, and they became deaf. And so just this week they had on TV a young boy, I'm going to say it was like 8 or 9. It seems to me I could have his age wrong. And they showed him getting a shot. And within a couple of months, he went from 0 ability to hear to 70% of hearing because they killed this infection with this DNA sequencing and creating this antiviral for what this child had. So we're going to hear more about that as that goes along. So you see, this is just in its infancy. But if you could find somebody in an academic medical center that was interested in experimenting with this, it would be a research project. You could hit the jackpot on that. Now, would that be possible that you would find somebody? Well, you're going to be looking for that needle in a haystack. I don't know if that person exists, but this is the kind of thing that we're going to be doing a lot more and hearing a lot more about in the future. So those are some things to think about. It's for this particular gentleman is getting that wound cleaned out and then working on healing that particular wound. Another thing that they are doing now that is available now is electrical stimulation to the wound bed to help stimulate that circulation and to help make that make that wound heal faster. So that is something that's available now. Now they probably don't want to do that with that infection there because that's going to be closing that infection inside your body, which the only place it's going to have to go is to spread throughout your body. But once that wound is healed up, then ask if electrical stimulation for wound healing would be the right thing for you because that really helps heal things. Some other things that people are doing is the hyperbaric oxygen chamber where they can put a device right over the area and do it locally, or sometimes you have to go in like what they call a tank. And sometimes it's more like a tube that you lay in, and sometimes it's like a little tiny room where they put high pressurized oxygen in there so you get more oxygen to that wound. There are people that have that treatment and that was the greatest thing they ever had. I have had people that have had that treatment and they're just like, it did nothing. So why that works for some people and doesn't work for other people remains to be seen. And, there's a lot of investigation that goes on with that, but those are a couple of things that you can do now. But I really think it's going to be interesting with these vaccines to see how that will help because, it could help maybe all sorts of things. Another thing that's in the news right now that we're hearing a lot about is Neuralink, which is the Elon Musk implant into the brain. It's a little disc. It looks to me to be like a little bit bigger than a quarter, and it attaches right into your brain. So you have to have brain surgery. So now that's pretty serious. You want to think about that very seriously, but all the different things that you can do and how that will connect. There's a lot of hype about it in the world of ALS for people who have difficulty communicating. It's supposed to help people. The first person that they've done, it's been successfully implanted, but that's all. Just the surgery's been done. So we don't know about, how it's working out. They'll take time to learn to use it. But then a computer helps navigate and create these impulses to help your body move. Now, the one thing that we do have right now are these functional electrical strips that are put over the spinal cord that are coming to market this year. And I'm hoping that that works out. It got delayed a lot by the COVID. I think some of those processes got delayed. And we've had Onward on to talk about theirs. We've had Spinex on, and I know that Zach's going to put up a list here of all the different companies that have been working on these nerve stimulators that help people do things. And so there was another person who wrote in about that. What's the pros and cons of these? Well, the pros certainly is that you get some return of function. And another pro is that once you put that strip on, you turn it on and maybe you have it higher in your neck because you want more hand function. Maybe you have it lower in your back because you want bowel and bladder and sexual function. So, it just depends on what your needs are and how it's going to work. Now, I don't know of one that runs the whole length of the spinal cord. They're only so long, and it seems like you do it either upper or lower or somewhere in the middle. So, will they make a longer one? Well, I don't know. They have implants that they can put in your body on your spinal cord, but right now they're still working on those. But right now these strips, they're non-invasive. You don't have to have surgery. What are some of the problems? Well, if the strip fails, you can have complications on your skin if one of the electrodes doesn't have the covering on it or something. So you have to look at them and make sure that they're still intact when you're doing it. Some people say, well, it's forcing messages up the brain in nerves that usually carry messages down from the brain. And will that affect those nerves? Well, over the long term, I don't think anybody really knows those answers. But for the people who've been doing the functional electrical bicycling for say 20 or 30 years, it has not affected them in that way. So I don't have proof that it doesn't. but there doesn't seem to be any evidence that it does. So that's a question. That's an uncertainty. But the people who have had these devices have just loved them, because they get function. They thought it would take, time for people to learn to use them. It seems like people get them, the electrodes placed on the skin of their back, and they like figure it out right away. It's like, oh my gosh, all of a sudden this is working. Now, I'm sure that that is for not everyone. I'm sure some people it takes longer to learn. But the one thing that we do know about these is that when you turn it off, or when you take the electrodes off, there's what they call a hangover time. And you still have this function without the device being there. So those nerves are still carrying that stimulation in some way. Pathways will be formed. At least this is the theory, that pathways will be formed, and maybe you won't need to have that for a lifetime, or maybe you will. Nobody knows the answers to these questions. So you wanted the ups and downs. So these are the ups and downs of it. Now, there are some people that are not interested in this at all. And I want you to know that that's just fine. There are some people who are thinking, gee, it's kind of new. I'd like to wait a year or two to see how it goes. And that's just fine. You have to do what's right for you. To quote a friend of mine, do what's right for you, Linda. I love him. And then there are some people who just never want it because they're getting along just fine. Doesn't really have any room in their life, and that's just fine. But learn about it so you know what your options are, and then you decide if it's right for you. It's not like we're saying, "Oh, you have to get this. This is the end all be all." It's not like before you had your injury or before you had your disease. They're also using this electrical stimulation for people who have stroke and for people who have brain injury. It might be not on the spine, but it might be on the arm, if that's the issue. Now, for walking, um, it helps with balance. It helps with posture. There's also a side effect that it helps the heart. It helps your breathing. It helps your blood pressure. So there's a lot of those things that the autonomic nervous system automatically controls that is having results with these particular electrode implant surface implants. So there's just a lot that's going on with this. Also, if you have just one limb that's affected, as in brain injury or in stroke, there's like this thing that it's like they call it a glove, but it's more like a bionic hand, and it fits on the surface, and it will help with hand function and arm function. So it's good. But for walking, these devices are devised for walking, but walking involves more than just standing up and moving your legs. Okay, there's coordination, there's proprioception of knowing where your body is in space. So if you have no sensation in your leg and it's moving, but it's not moving exactly to the right spot where your foot needs to land, there's a good chance of falling. So that proprioception and coordination, that is really a big hurdle I see for walking, my opinion. Others may say differently. But some people are using these surface electrodes to be able to stand and walk with a walker. Again, this is not like pre-injury or pre-disease, but it's an improvement on what you have. So, again, it's like, is walking that important to you? For a lot of people, it's not. They're very comfortable in their chair and they get along well. So for some people, it's more energy. Lifting and balancing and coordinating your body that you don't feel is a big challenge. You could talk to Christopher Reeve. He would tell you it was a big challenge for him. So these are some of the things to think about with those. The Cleveland Clinic um, in Ohio, they do implants, and it's kind of neat. We're going to have the people on from the Cleveland Clinic later on in this year. They have a implant that's kind of modular. So if you need something for your right leg, but not for your left leg, or if you want something for bowel and bladder, and then it can be expanded to your legs, and then you want to expand it to your arms, or you want to start with your arms and then expand it, so there's all kinds of things. Now, some people get all in a dither because this is functional electrical stimulation, and we're not quite sure. But people use functional electrical stimulation for things that we don't think about. For instance, cardiac pacemakers. That's functional electrical stimulation. Cochlear implants for hearing. That's functional electrical stimulation. There's all kinds of things. We had Dr. Raymond Anders, who does a diaphragmatic pacemaker. That's electrical stimulation, and he's getting a lot of people off the ventilator. So there's just all kinds of things that are going on in that world. That is the big piece of the puzzle right now. That's they're working on all the pieces of the puzzles, but that one's coming to fruition now. Okay, we're going to really change gears here because somebody has a question about, does removing metal fusions improve motor function? And I'm going to say the basic answer is no, because those metal screws that are holding the rods there are stabilizing the spine, the bony part of the spine. They're not affecting the spinal cord. Now, sometimes, like if somebody breaks their leg, they'll put in a plate and they'll put in the screws, and then they'll go back later and take that out after that bone has healed. But the spinal vertebrae, the bony part, are bones on top of bones on top of bones with ligaments in the middle. So there is some flexibility in there. You put a plate in there, then these two vertebrae don't move. There are some there's a new technique that's out. And instead of using the metal rods, they're using flexible rods, which gives you some flexibility in your vertebrae. So you could maybe tilt a little bit like this, but you're not going to be able to tilt like that because of the rods in there. That's also done with minimally invasive surgery. Instead of a long incision and going down all the vertebrae, it's just little incisions at each vertebrae. So it's kind of cool. That's newer on the market as well. So that gives people a little more flexibility. But does removing that increase your function? No, unless one of those screws is tapping up against the spinal cord, which is something that shouldn't happen, but weird things happen. Or maybe a vertebrae has collapsed and it's come out of place for some particular reason. But those are really odd sort of questions. So the basic answer to that, does removing the metal fusions improve motor function? Not really, or at least it shouldn't. But anything can happen at any time. So we'll have to stay tuned on that one. Let's see. There's a gentleman who has been a victim of crime and has an incomplete paraplegia. His two main barriers are his rehabilitation services. He has Medicaid and he has only had 3 appointments. Okay, now that is confusing to me, and I'm wondering if there is a miscommunication. Oftentimes, people are given, if you have Medicaid, if you have Medicare, or if you have private pay insurance. When you go to rehab, people are given so many attempts, like they'll get like 2 weeks of rehab, and then it has to be reevaluated. If the person is making progress, they'll get 2 more weeks. And it's this whole process. And they have a whole department, the nursing case managers in the hospital do nothing but talk to the insurance case managers. And, it's these layers of things that makes things more complicated. But insurance is not going to just give carte blanche and say, oh, you can have 16 treatments. They might say you have 3 treatments. And if they're making progress, then we'll give you more treatments. So I'm hoping that is just a miscommunication. So in this case, since I don't know what the situation is and I don't know why it is that way, but be sure and look at your Medicaid, look at the Medicaid card. There will be a number on the back for the owner of the card, or you as the advocate for the person can call in and talk to the insurance company and request a nurse case manager. That is the person that you need to work with. Now, that's the nurse case manager from the Medicaid. Catastrophic cases such as spinal cord injury usually have a nurse case manager assigned right away, but that doesn't mean that happened, but generally that's the way it works. And so call that number on the back of the card, find out if there is a nurse case manager assigned to the case, and then if not, ask for a nurse case manager to be assigned to the case, and then talk to that nurse case manager about your concerns. This is what's going on. What can we do? How can you help? And all those kinds of things. Because Medicaid is provided to people who need this sort of help. So I'm thinking that there's just some kind of little link in the system. You know, if he was going to therapy and he wasn't participating, I know you indicated there's some other issues that are confounding this. If he wasn't participating or if he wasn't able to follow the instructions, you know, talk to that nurse case manager and say, well, that was happening at this point in time, but now this is happening. Or, since if he can't do these things on his own, could I come in with him and be educated on how I take care of him with these issues? So, there's a
Hi, everyone. It looks like Nurse Linda just froze, so we're just going to give it a moment and see if she comes back. So please just bear with us. Thank you. Hi, Linda. Are you back with us?
I am back. I'm not sure where I left off, but I am back. Let's see. I'm trying to get back. Can you see me?
Yes, I see you,
Okay.
and I can hear you, and I've just added you to
Okay.
my spotlight.
I can't see or hear anybody, but that's okay because I can still talk. So anyway, be sure and talk to that case manager and ask for options. If your son wasn't doing well at that particular time, sometimes people just need some time to heal, to kind of get back into life, to see that they're going to be okay before they can really participate in therapy or treatments. Sometimes maybe if you talk to the case manager and say, I need more education because he can't do these things, so I need education. We need to come together and learn how to do these things. So these are all things that might help you with getting that accomplished. As a person with spinal cord injury who has lots of spasms in their legs, and he takes dantrolene, is massage helpful? It's not really too helpful. Range of motion is very helpful, very gently moving every joint in that body, and you can look and see how to do range of motion. I have a blog for that somewhere in the files there, and Zach will magically find everything. So that really helps. Most people are going, instead of like with dantrolene, and this is the same for people with stroke and head injuries. Sometimes their joints get tight because you have pushing muscles and you have pulling muscles. The muscles that push are generally a bit stronger than the muscles that pull towards you are generally a bit stronger than the muscles that push things away. So that's why when people get spasms or contractures, their body tends to their extremities tend to draw towards their body. So people with stroke or head injury, you might see them with a contracted arm. And what they're using mostly now is Botox to relax that muscle. The Botox doesn't travel through the rest of the body like the dantrolene does. And so people are more opting for that treatment right now. Now, if the arm is contracted, there will need to be doing some sequential stretching with braces or other kinds of treatments to stretch out that arm. And then these Botox injections help relax those muscles. But if the muscle's contracted, it's shortened. And so you've got to get that going back out again. So Botox is really what people are doing these days. But there's all kinds of medications that will help um, with spasms. So antispasmodics, anti-epileptics, anticonvulsives at real low levels. Not that it doesn't mean they have epilepsy. It doesn't mean that they have depression, but it will help just at a tiny little, like 5 or 10 milligram dose. So it's not even treatment for those other kinds of things. Interestingly enough, people who are on treatment for depression or they have seizures for some odd reason, they have very little spasticity and contractions because it's a side effect of their medications. So that's kind of an interesting little sidebar fact. Here's a person that what can they do about their dysreflexia? It's making their face sweat and it's turning their hands cold. There are medications to treat dysreflexia. So there's the nitrates, like different nitrate medications. There's hydroxyline. There's Labidol, there's nitrophenidine. I wrote them all down over here. Can you see me looking at my list? Clonidine, phenothiamine. So there are all kinds of medications. And when you have a spinal cord injury, or sometimes when you have a stroke, spinal cord injury, people don't usually sweat below the level of their spinal cord injury, although there's another phenomenon where all they do is sweat below the spinal cord, the level. But when you get that sweaty in your hands and your face, it's usually because that's where you can sweat. And so that's why that happens. People who have stroke might only sweat on one side of their body and not on the other. Same for head injury. So that's another thing. Let's see. There's somebody who wrote in about getting information because they work at a rehabilitation hospital. And I would just like to point out that for people in the community, for family members, for healthcare providers, for anybody who is interested, there is an abundance of information about paralysis from the Christopher and Dana Reeve Paralysis Foundation. Now, interestingly enough, the people who get information about paralysis are about 50% with spinal cord injury, about 50% with head injury and stroke, because our other diseases as well, because all of the neurological diseases can result in neurogenic bowel and bladder, can result in paralysis with decreased sensation. So all of the information can apply to different people. You just need to know, does my family member have a neurogenic bowel or bladder? And if they do, the doctor will tell you it's a diagnosis that they have. You can go to the Reeve Foundation and there's just all kinds of free information on how to do a bowel and bladder program. There's information about pressure injury. There's information about just everything you could possibly need to know about paralysis, and it's all free. You can download the information straight from your computer. You can request the information and they'll send a booklet to you. You can call them, the information specialist. I'm sure Zach's put up their number, but I'm sure you wouldn't mind putting that up again. And they will send you that information that you need or desire, and you can flip through that. There are blogs. There's the peer mentoring program. If you feel like you're out there and you're kind of on your own and you need a little more information about people who are living the experience, they will match you up with somebody who has the same kind of characteristics as you do. And by that, I mean, if you're a 40-year-old male with a lower level spinal cord injury, they'll match you with a 40-year-old male with a lower level spinal cord injury. If you're a young mother and you have a different kind of injury or disease, they will match you with a young mother with a different kind, so they look at those kind of things, and they get people matched up. And the peer mentors that I have met, and there have been quite a few, and I want to say hello to my group in Texas, because what a wild bunch they are down there. They are so much fun. They are living life. And that's half of the ability, is to be able to successfully live life and enjoy it. so they're very patient, they listen, they have a lot of good ideas, but you know what? They're out for some fun. And when they get together, let me tell you, it is a good time. So I spent a wonderful evening with those guys down there in Dallas, Texas. So hello to you all. Fabulous. So anyway, what else is going on out there? Um, there's another question about tone and tightness. We talked about that. New things in wound care that we went over a great deal about. Um, so I think that is all of the questions for today. I'm going to try to, I don't know why I can't make this big all of a sudden. Here we go. Here we go. I'm going to check the chat box one more time. Oh, have stenosis and carpal tunnel, both arms, T5 para, both severe prognosis. Well, now this is the thing. People who have, people get carpal tunnel syndrome, especially paraplegics that are manipulating their wheelchairs because of the way they push the chair. They're pushing their wheels and this is stretching that area where the nerve goes through there, but the tunnel is it's a ligament, it's like gristle that the nerve just travels through. So if you get splints, you want to straighten them out, because night splints, sometimes they'll say, oh, we'll sleep with some night splints, or wear night splints all the time. Well, night splints are built for the function of the hand. And so if you would get a contracture in your hand, this would be the most functional position. So, but it's stretching that nerve even more. So just get some, if you want to try some splints, check with your healthcare professional first, get some splints, make that metal piece that makes your hand stretch out like this, make it so it's flat. You only need to use them at night. Talk to your healthcare professional, since you have this, and surgery will really put you behind the 8 ball, because then you can't use your hand. They'll do one hand at a time. So then you're without your hand, you can't transfer, you can't put weight on your hand. It can be a real problem. But some people, and yours might have progressed too far, but some people, when they'll wear a night splint at night to rest this, because at night you move around, your hand flops around, and that aggravates it. So wear the night splint at night to keep it immobilized. During the day, you don't need to do that, because in the daytime, you're aware of where your hand is, and we're not usually flipping around like that in the daytime. So usually that will take care of the problem if it's not too severe, but it sounds like yours is really out there. So ask your healthcare professional about a power assist device to your wheelchair. Now, those are very heavy, but you hardly even have to put a finger on that thing, and your wheelchair is going to take off. So they're very heavy for getting them in and out of the car. So, it's something to think about. Sometimes it's just in the wheels, but then the wheels have to come off, and they're heavy to get in and out of the car. If you have a lift, or if you have a van, well, then you're golden. But there are pros and minuses to these. But since you are probably transferring by pushing your hand down, see if there's some transfer devices that you can get. You have a medical condition, so you probably are eligible for some of this equipment. If you can get them now, while the timing is right, get them now, because they're kind of nice. It will help protect your shoulders and your elbows, help prevent further issue in your wrists as you get older. So it will be kind of nice. Now, you might have transfer equipment that maybe you use at home, but when you go out, maybe you don't have that equipment available. And, most people find that that's okay, because the majority of their transferring they're doing at home, from bed to bath, shower, or wherever. You can also get catheter extenders, or get bags if you're catheterizing and you don't want to transfer onto the toilet. Maybe you're out at work or school, or you're, in a public bathroom. You can request that maybe you get catheters with a leg bag, or some different kind of alternative catheters, so you can go in the bathroom, catheterize yourself, but you don't have to transfer onto the toilet to catheterize. Bowel programs are usually done at home, usually not out in public. So unless you need to manually evacuate your bowel, then you would probably need to transfer onto the commode. But you could probably do that before you go out, and then maybe after you come back, depending on how you regulate your bowel program. So I hope that's some help, but you should be able to get some equipment to help with your transferring and your mobility now, so that the situation doesn't get worse, and maybe it might even improve a little bit. So we'll keep a positive thought out with that. And with that, it's at the top of the hour. So I thank you again for all coming. It's always wonderful questions, and I just appreciate it so much because you guys really put me to task at putting my thinking cap on. So thank you, and we're headed into hopefully some nicer weather. Be sure and bundle up. Remember, even if you don't feel the cold, your body does, and your body reacts to it. So stay safe.